This is Spencer King. Welcome you to this session of multivessel revascularization after FAME-3. We've got a wonderful panel organized today. I'm a chair along with Dr. Ducwo Park and Dr. Javier Escanad, and we will introduce our speakers as they come along. I will give an introductory talk, which will probably step on some of the information for the subsequent speakers who are real experts in this activity. But the fact of the FAME-3 trial, which now has come out since the guidelines, I think will be interesting to all the participants. Dr. Park?
Okay, so thank you. And I think that this session is one of the highlight session that recently we are see, and the main result of a FAME-3 trial this time is a very nice discussion, interventional cardiologist and cardiac surgeon. So I would like first the speaker and the moderator, Professor Spencer King, and he will talking about introductory keynote revascularization after FAME-3. How will we decide? Professor King, please.
All right. I've been fascinated by the new guidelines suggesting how we should approach revascularization. And subsequent to those guidelines, we have the FAME-3 trial, which was not available at the time of the guidelines were written. So I think our charge today is to examine FAME-3 in relation to the guidelines and how they might change in the future. I'm followed by two expert presenters who will present in more detail. But first of all, let me proceed with advancing my slides. All right, the guidelines that have been released have instructions around left main disease and multivessel disease. And as you see, and I'm going to concentrate totally on stable ischemic heart disease, not on STEMI, because I think that's what the FAME-3 dealt with. We are faced with questions about left main. The evidence from past studies would indicate that, as indicated here under left main, that the recommendation is for surgery for patients with left main disease in general. There's also a recommendation that if patients can be revascularized comparably by PCI and low risk of left main interventions without other extensive disease, that can also be recommended as a 2B, that is, should be considered. So in left main disease, it's very clear that surgery is the main recommendation. In multivessel disease, the so-called triple vessel disease is being discussed here. Both surgery and PCI are recommended. It's interesting that both are given a 2B recommendation. But the language is a bit different. And the surgery recommendation, it is that surgery may be reasonable. Surgery may be reasonable. In the PCI, it says that usefulness is uncertain. Usefulness is uncertain. Now, these are recommendations about survival, and they're based on the past studies. The recommendations for relief of symptoms, I will not go into much, but basically revascularization is indicated for anyone with symptoms with appropriate lesions that can be addressed. Diabetes takes also a center stage in the guidelines and is emphasized. I know that FAME-3 has a small under 500 patients with diabetes. We'll come to that. but in the guidelines, there's still a bias toward recommending surgery for patients with diabetes in situations where PCI and surgery are considered. For patients with complex disease, there is a discrimination. It says in patients who require revascularization for significant left main disease with high complexity, it is recommended to choose surgery over PCI. Now, this high complexity is defined as not only the left main being complex, but also a high Syntax score representing disease in the other vessels. That is given as class 1, that surgery is recommended over PCI for the most complex of the left main. In patients with multivessel disease, that is a Syntax score above 33, the guidelines say that it's reasonable to choose surgery over PCI for survival advantage. So that's where we are with the guidelines. Now comes the FAME-3, and you'll hear a lot more about this from the subsequent speakers. But FAME-3, briefly, was a study of stable ischemic heart disease with 3-vessel disease randomized to surgery or to FFR-guided PCI with 1,500 patient target, and that was achieved. The primary endpoint of death, MI, stroke, or repeat revascularization, and I emphasize that repeat revascularization was an endpoint in FAME-3. It was a non-inferiority design. It was designed to show that PCI was non-inferior to surgery for patients using FFR guidance. Diabetes represented about 30% of the patients. The ejection fraction was under 50% in 18% of the patients. And CTOs, chronic total occlusion, was present in 21% of the patients. Syntax score was 26. And the breakdown of that was that the lower tercile Syntax score was present in 33%, the intermediate in 49%, and high Syntax score in 18%. So these patients were not terribly dissimilar from the previous Syntax trial done about 10 years before, and we'll come to some comparison of that in a moment. Well, what was the outcome? Well, for that composite outcome, it turns out that PCI was not proven to be non-inferior to surgery. You see here the expanded Kaplan-Meier curve for non-inferiority with surgery showing fewer events than PCI. Now, let's take a look at the Syntax score and how that broke down. For the primary endpoint, in the low Syntax score, 0 to 22, and remember about 1/3 of the patients had a low Syntax score, it turned out that numerically, surgery had a little higher number of events than PCI. But in the intermediate and high Syntax score, clearly PCI had more endpoints. It was more adverse than surgery. So the total, as reflected in the Kaplan-Meier curve, was 10.6% MACE for the PCI group, 6.9% for the surgery group. As far as the specific endpoints, I like to always look at those. No difference really in death and stroke and MI, not very different. The repeat revascularization, perhaps predictably, was more in the PCI group than in the surgery group. And most of that repeat was, in fact, was PCI in both groups. There was not repeat surgery in the FAME-3 trial, or very rare. So However, in bleeding, not surprisingly, surgery had higher bleeding events, and more people were rehospitalized following bypass surgery. Almost all of the subgroups trended toward surgery, and some of those are interesting. But the main one that everyone was interested in going into this trial was the Syntex score. In other words, if the patients did not have extensive disease, would it be fine to do PCI rather than surgery? And the FAME-3 trial doesn't prove that, but it does show that the patients in the lowest Syntex score group did have endpoints that were not greater than the surgery group. In fact, a little bit better. Now, a lot of this planning for FAME-3, I guess, was predicated on the fact that physiology, the measurement of FFR, was going to be better than using just angiographic methods for judging, for planning PCI and conducting PCI, because FFR had been shown to be better than angiographic measures in some trials, including the FAME-2 trial. However, we now have a couple of trials looking at FFR that brings into question, I guess, the value of measuring FFR to guide these procedures. The Flower MI trial was a STEMI trial of over 1,100 patients, where the culprit artery PCI was followed by angiography-guided versus FFR-guided non-culprit intervention. And indeed, non-culprit stenting was less. It was 1 per patient in the FFR group and 1.5 stents per patient in the angiographic guided group, so fewer stents were placed, but the primary endpoint was not different. So this trial was indeed negative. Another trial was the Future trial, which was stopped prematurely because of concern about mortality, which proved not to be the case when all the data was reviewed. But this was a sort of an all-comers trial with FFR guided versus angiographic guided strategy for multivessel coronary disease. And once again, the primary endpoint here, a death, stroke, or revascularization, was not different. So another negative trial, although it was stopped early. So the question of FFR guidance will be interesting to discuss. I'm sure our presenters to follow will enlighten us about that. The good news, however, is that after the FAME-3 trial, if those results could be compared to the Syntex trial from 10 years ago, and if you accept that the patients are somewhat comparable, then FAME-3 had a lower incidence of repeat revascularization, 4.9% versus 13.5% for the Syntex trial, and also a lower mortality, FAME-3 1.6% versus 4.4% in that Syntex trial. Now, this may be due to improvements in stenting technology, surgical technology, and so forth, but it probably has a lot to do with improved medical therapies, much more aggressive medical therapies, as well as probable differences in baseline characteristics of the patients. So I'll conclude these introductory remarks by saying, asking the question, how do we select revascularization methods now after the guidelines and after FAME-3 study? The guidelines I've shown you, we've been through those, and to some degree, they do recommend heavily for surgery for left main disease that's complex. They say it's okay to do left main and less complex left main disease. They emphasize the heart team. In triple vessel, they put a lot of emphasis on ventricular function, aiming towards surgery for bad ventricles. They recognize that for patients with good ventricular function, that CABG and PCI are both okay. So my conclusion is that we don't necessarily do the same kind of things that the guidelines say. Here's a patient with 3-vessel total occlusion, underwent angioplasty with stenting to the circumflex, then followed by opening up a totally occluded right and then a totally occluded LAD. Perhaps I would have sent this patient for surgery based on what I understood from the guidelines, but these kind of things are being done commonly with good results of PCI. So I think we should consider the guidelines and the FAME-3, but also very much local expertise and experience in making decisions. And having said that, I think in the future, diagnostic angiograms will be replaced by coronary CT angiography. Non-invasive physiology, such as FFR and plaque characterization, will be collected. Biomarkers may be added, and with these technologies, perhaps we'll be better able to predict which patients will suffer cardiac events and which lesions will be responsive to revascularization and therefore better select treatment options. So how will we select revascularization after FAME-3? I think it will be pretty much as we did before FAME-3. Thanks very much.
Thank you. Great introductory keynote lecture from the Professor Spencer King. So I would like to move to next speaker and Professor David Paul Taggart from Oxford University, and he's a representative of the surgical part. He will talk and the bypass surgery for multivessel disease surgeons approach.
Great, thank you. So let me start by saying first, could I thank the organizers, especially Dr. Duck Park Wu and Dr. S.J. Park. And I'm delighted to, and honored to give this presentation today. And I have to say, I think like many of us, we would much prefer to meet in person, because despite some differences in views about the science of what we do, I think we've all remained a good and very healthy friendship over a long period now. So I'm going to look at FAME-3 and how it may interfere or give us some guidance on how we should treat patients by PCI or Cabbage. I will declare my conflicts of interest clinically as a cardiac surgeon, but I will genuinely try to present all the relevant data in a balanced way. And I do have some commercial interests, but none of them relevant to this presentation. So when I look at FAME-3 in terms of PCI and Cabbage for multivessel disease, and I emphasize not for left main disease, there's a number of issues I think we need to take into consideration to get the big picture. We need to look at the evidence for coronary artery revascularization, and I exclude both ischemia and Excel because neither are relevant to this presentation. I'm going to give a general caution in how and why we should interpret trials. I will then look at 3 specific cautions in interpreting trials of PCI versus Cabbage. We'll then discuss the evidence basis for PCI versus Cabbage both before and after FAME-3. We'll look in the specific subgroups of diabetes and impaired ventricular function. We'll then try and understand why there always appears to be a persisting survival benefit of Cabbage over PCI. We will then touch on guideline recommendations and the current controversy, comparing the European and the North American guidelines, and then some practical considerations for PCI versus Cabbage. I start with this quotation from Marcia Angle, a former editor of the New England Journal of Medicine in 2009, when she said conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. So when I look at trials of Cabbage versus PCI, I always have 3 cautions and 3 key rules to follow when I'm trying to interpret data. The first is, who are the trial patients? Are they typical of real practice in terms of coronary artery disease severity? And the answer to that is no. They're usually highly selected patients with less severe coronary artery disease. And therefore, this serves to underestimate the true benefits of Cabbage in routine practice, where most patients have more severe coronary artery disease than trial patients. The second question I ask myself is, what is the duration of follow-up? And in my opinion, it must be a minimum of 5 years. Ideally, it should be 10 years, as in the ART trial, Syntaxes, and Stitch, because what you always see is that with the increasing length of follow-up, there's an increasing and accelerating benefit of Cabbage. The third question I ask myself is, what was the use of guideline-directed medical therapy in the trials? Because frequently, Cabbage patients receive significantly inferior therapy compared to those in the stent group. And the implication is, if the Cabbage patients receive the same medical therapy, then the benefits over PCI would be even greater. And based on this, I always have a general tip that I say, if you're examining a trial, always look at the data and the results before reading the text. And why do I say this? Because the text will often have a very pro-PCI bias, and often the text will actually contradict what the actual data shows. And a classic example of this was the mortality data in the Excel trial. But data consistently shows superiority of Cabbage for survival, MI, and repeat revascularization. And Dr. King mentioned the Syntax trial, and I go back to it because I still think it's the most important data we have. This is now almost 10 years old, but the 5-year outcome of the Syntax trial for Cabbage over PCI at 5 years had a very significant reduction in the risk of mortality, cardiac death, myocardial infarction, and repeat revascularization. And the other thing that Syntax told us was the importance of the Syntax score reflecting severity of coronary artery disease. So in the low severity group, less than 23, the mortality difference was 1% in favor of Cabbage at 5 years. But in the intermediate group at 5 years, it was 7%, and in the high-risk group at 5 years, 9%, and accompanied by significant reductions in myocardial infarction and repeat revascularization. And this data holds true outside Syntax. This is from the PART group. Dr. Duck Wu is one of the authors in this, showing what is the long-term mortality after coronary revascularization in non-diabetic patients with multivessel disease. And they concluded that at 5 years, Cabbage, as compared with PCI with drug-eluting stents, significantly reduced the long-term risk of mortality in non-diabetic patients with multivessel coronary artery disease. And this story is just never-ending and repetitive. This is a publication in The Lancet led by Stuart Head, looking at over 7,000 propensity-matched patients, relatively low Syntax score with a mean of 26, and showing that at 5 years, the hazard ratio for death with PCI is almost 30% higher in the stent group. And if you look at the shape of the survival curves, you can see that they are accelerating in favor of Cabbage. If you look at the extended 10-year follow-up of the Syntaxes trial in The Lancet in 2019, almost 1,100 patients, again, relatively selected with a mean Syntax score of 29. But we can see that even at 10 years, there's a 40% difference in mortality in favor of Cabbage, and it continues to accelerate. So if we now turn to FAME-3, presented at TCT in October 2021 with a simultaneous New England Journal publication, 1,500 patients. Now, what's important here, this was PCI at its best. It was FFR guided with the best drug-eluting stent. If we look at the primary endpoint of MACE, the usual composite MACE points, and a wide non-inferiority upper limit was chosen of 1.65. And these are 1-year results, not 5 and not 10-year results. And over 80% of patients had low or intermediate Syntax scores. And what did we see at 1 year? The MACE rate for PCI was 10.6 versus 6.9 for Cabbage. So this did not reach non-inferiority. And if we look at this graphically, we see the same worrying features we saw in the Excel trial. In FAME-3, even at 1 year, there's an accelerating difference between PCI and Cabbage. And you have to ask yourself, what would these results look at 5 years? And then, as Dr. King mentioned, if you look at the subgroup analysis, almost all of them are either statistically significant or trending towards statistical significance. And again, I emphasize, this is at 1 year, not 5 or 10 years. If we turn to patients with diabetes, then the most definitive study is the FREEDOM trial, 8 years follow-up published in JACC in 2018, where the authors conclude in patients with diabetes and multivessel disease, Cabbage leads to lower all-cause mortality than with PCI and drug-eluting stents in long-term follow-up. And remember, these were patients with diabetes with relatively low severity coronary artery disease. And when the authors re-examined these patients according to syntax scores, they concluded that Cabbage was superior to PCI for every level of syntax score and recommended Cabbage should be the preferred method of coronary revascularization, regardless of the complexity of the coronary disease. Despite this, in the ischemia trial, in the patients who were referred for early invasive angiography and revascularization, despite the fact that many of these patients had diabetes, over 80% were still treated with stents rather than coronary bypass grafting. So all the evidence was ignored. If you look at this large propensity match study from Ontario, 8,600 patients, comparing PCI and Cabbage, we can see that at 8 years, there is an 8% difference in favor of Cabbage over PCI. And in this nice pictorial graphic, we show the difference between PCI and Cabbage and diabetes. For 30-day mortality, no difference. For all-cause mortality at 8 years, 8% absolute difference and accelerating. For late myocardial infarction, 9%. No difference in the incidence of stroke. And for overall repeat revascularization, almost a 20% absolute difference in favor of Cabbage. If we turn to ischemic cardiomyopathy, then we look at the STITCH trial, which showed us the advantages of Cabbage over medical therapy in patients with impaired ventricular function. It is just approaching statistical significance at 5 years, but you can see it then accelerates, and at 10 years, an absolute difference of 7%. And this is despite the fact that 20% of the optimal medical therapy group actually got Cabbage. And in this large study by Mark Gruel's group, it shows almost 5,000 patients undergoing PCI or Cabbage with impaired ventricular function and ejection fraction below 35%. These patients were matched for 30 baseline characteristics and followed out to 9 years. And what do we see? A very dramatic difference in survival in favor of Cabbage, accompanied by significant reductions in MACE, myocardial infarction, and repeat revascularization, but no difference in stroke. So I come back to this slide of mine, which I've now been showing for 20 years. So you've probably seen this before, but I still think it's highly relevant to what we see today. I think there are 3 reasons why Cabbage has a persistent survival benefit over PCI. The first is that anatomically, atheroma is mainly located in the proximal coronary arteries. So placing bypass grafts to the mid-coronary vessel has 2 effects. It means that the complexity of the proximal culprit lesion is irrelevant, and it means that over the longer term, Cabbage offers prophylaxis against future proximal culprit lesions. In contrast, PCI only treats suitable localized proximal culprit lesions, but has no prophylactic benefit against new disease. The second difference, as Tom Lucier showed us more than 3 decades ago in the New England Journal of Medicine, is that the IMA elutes nitric oxide into the coronary circulation, and this reduces the risk of further disease progression. In contrast, drug-eluting stents can impair re-endothelialization, cause downstream endothelial dysfunction, and create a pro-thrombotic environment. And the third, and the third difference is PCI still means for many patients incomplete revascularization, and this has been repeatedly shown to correlate with both subsequent increased mortality and MACE. And I would argue this is why PCI is unlikely to ever match the results of Cabbage for most patients with left main and multivessel disease. It hasn't with balloon angioplasty, bare metal stents, drug-eluting stents, and even the latest generation of drug-eluting stents. And I think that's what FAME-3 is telling us. If we look at the ESC-EX guideline for myocardial revascularization in 2018, excuse me, they show that for 3-vessel disease without diabetes, which accounts for almost 80% of patients, there's a 1A classification for Cabbage and class 3 for PCI. And those recommendations become exaggerated in favor of Cabbage if the patient has diabetes. But I would also argue if Cabbage was performed with more arterial grafts and better use of optimal medical therapy, then these differences would be even greater in favor of Cabbage. However, we have to use common sense. There are indications when PCI should be chosen over Cabbage. So clinical characteristics would be that would favor PCI are elderly, frail patients, or those with low severity anatomical disease, where I think PCI does offer good results. On the other hand, what favors Cabbage is high anatomical complexity disease and certain patient characteristics, as I've discussed, diabetes and reduced left ventricular function. Now, Dr. King mentioned this. This is a recent 2021 publication by ACC, AHA, and SCAI for coronary revascularization. And I don't have time to go through the manuscript today, but essentially there's a significant downgrade in previous recommendations for Cabbage in comparison to PCI. Now, this has been rejected by the American Association of Thoracic Surgery and the Society of Thoracic Surgeons in the United States, the two largest surgical organizations. And it's now been rejected by the European Association of Cardiothoracic Surgery, Indian and Asian Societies of Cardiothoracic Surgery, and the Latin American Society. And the three concerns expressed by the surgeons were the downgrade of the recommendations for Cabbage in the absence of any new scientific evidence. Cabbage has been downgraded from a class of recommendation from 1, which is strong, to 2B, which is weak, versus medical therapy. The second concern was the lack of recognition of the superior long-term benefits of Cabbage over PCI with regards to survival and reduced myocardial infarction and repeat revascularization. And the third concern, which is more a technical aspect for surgeons, was the increased class of recommendation to 1 for a radial artery in Cabbage as a conduit. So that would be the same for an IMA, but a higher recommendation with the use of 2 ITA grafts. So I'm going to round up my talk and say, I'd just like to show and advertise this book. It's a book edited by myself and John Puskis. It has 72 chapters on every aspect of coronary disease, from its pathophysiological features to its medical management, and then to what are the important surgical components. So on that point, I'm going to conclude my talk. I would like to thank the organizers, especially Dr. Duckwood Park, for the opportunity and privilege to speak today. And I genuinely hope that next time we have this meeting, it will again be in person as we used to do, because I think all of us miss the personal touch. On that point, I will conclude my talk. Thank you very much to you and the audience for listening.
Okay, great. Thank you. Okay, Professor King, can you introduce the last speaker?
Thank you very much. Yes, the last speaker of our session will be the author of the FAME-3 trial, William Ferron, who undoubtedly will be able to enlighten us on the outcome and his interpretation of this very important trial.
Thank you for the opportunity to speak about FFR-guided PCI for multivessel coronary disease in 2022. These are my disclosures. So in 2021, 3 major FFR-guided PCI trials in patients with multivessel coronary disease were either presented or published. The FUTURE study, the FLOWER-MI study, and the FAME-3 trial. And some have interpreted these as all negative trials for FFR or coronary physiology. But what I would like to try to do is convince you that that's not necessarily the case. So let's talk about the future trial first. This was a study looking at FFR-guided therapy in multivessel coronary disease patients. And these patients were randomly assigned to an FFR-guided approach to therapy, either medical therapy or PCI or Cabbage, or an angio-guided approach to deciding which therapy to apply. The primary endpoint was major adverse cardiac and cerebral vascular events at 1 year. The study was stopped prematurely after enrollment of 927 patients because of a signal for increased mortality in the FFR-guided group. However, the primary endpoint you see at 1 year was identical between the two treatment strategies. And when the investigators followed out the mortality rates in both groups to a longer time period, you see there was no difference in mortality either. And likely the early signal was the play of chance. So some have asked, well, why didn't FFR-guided therapy outperform angio-guided therapy like what was seen in FAME-1? And I think there are a few reasons. First, this is a fairly complex patient population with a relatively high syntax score, 19, and more than 50% of patients had 3-vessel coronary disease. In addition, 127 lesions with an FFR above 0.80, negative FFRs, received PCI anyway. And this was 27% of all of the FFR negative lesions. The study was underpowered with just 54% of the planned population enrolled. And finally, only 8% of patients received a different treatment in the two groups. And what I mean by that is if you look at the angio-guided group here and the FFR-guided group, as far as those assigned to optimal medical therapy, it was 9% in the angio-guided group and 17% in FFR-guided. So an 8% difference. The number assigned to Cabbage was essentially identical, which is surprising. One would think that FFR guidance would downgrade some 3-vessel disease patients to 1 or 2-vessel disease. And finally, those assigned to PCI was 8% higher in the angio-guided group. So only 8% of patients, or 35 to 40, in the FFR-guided group received a different treatment, OMT, instead of PCI than in the angio-guided group, which makes it hard to demonstrate any difference in outcomes. Let's now talk a bit about the FLOWER-MI study. This was a study looking at FFR-guided PCI in STEMI patients with multivessel coronary disease. Over 1,100 patients with STEMI who underwent successful primary PCI and had at least one other major vessel with a 50% or greater narrowing were randomized to either FFR-guided complete revascularization or angio-guided complete revascularization. The primary endpoint was death, MI, or unplanned hospitalization with urgent revascularization at 1 year. And what we see is that there was no difference in the rate of death, MI, or hospitalization, particularly if you look at the top curve here on the 100 scale. If you look on this really zoomed in scale, which is a bit misleading, it makes you think there might be a difference, but really there was no difference with broad confidence intervals. Now, when you look at the individual components of the primary endpoint, one sees that there were 18 non-fatal MIs, or 3.1% in the FFR-guided group, and 10, or 1.7% in the angio-guided group. But what is mentioned in the subtext is that procedural MI actually was diagnosed in 7% or 7 patients in the FFR-guided arm and only 2 patients in the angio-guided arm, which is a bit unclear, especially when the angio-guided group had 260 more lesions treated with PCI. Some other trial design considerations that are worth highlighting. it would have been ideal if randomization occurred after the operators had identified and stated which non-culprit lesions would be treated. Instead, there were more lesions identified in the FFR guided arm, 980, almost 100 more, compared to 891 in the angio guided arm. And this can explain why the contrast usage and the procedure time were similar between the groups. One would have expected these to be less contrast and shorter procedures with FFR, as has been shown in other studies. But this was not the case because so many more lesions were interrogated in the FFR guided group. In addition, of those 980 lesions identified in the FFR guided arm, the FFR value was missing in 154 patients. And there were 460 lesions with a low FFR, yet PCI was performed in 546 lesions in the FFR guided arm. So there were a fair number of patients who had a negative FFR yet received PCI anyway. And this may explain why an average of 1.1 stents were placed in the non-culprit lesions in the FFR guided arm compared with 1.5 in the angio guided arm, which is a fairly similar number of stents. In addition, it would have been ideal if FFR had also been measured in a blinded fashion in the angio guided patients. And the reason this would have been helpful is it would have allowed a comparison of PCI versus medical therapy for non-culprit lesions with negative FFR. Unfortunately, in the angio guided arm, we don't know which lesions had a negative FFR, and so we can't make this comparison. So was Flower MI a negative trial for FFR, or should we have expected better outcomes with FFR in this STEMI population? Well, first of all, both groups were presenting with a STEMI and underwent primary PCI, which was likely the most important indicator of outcomes and was similar in both groups. So we would expect a similar outcome from that. 66% of the FFR guided patients underwent non-culprit PCI, similar to what was seen in the angio guided group, and 3% of the angio guided patients did not have non-culprit PCI. So basically these were the crossover rate. And in these crossovers, you would expect, again, a similar outcome. So because of this, just under 200 patients in the FFR guided arm did not have non-culprit PCI and could potentially contribute to a different outcome. So a very small number when you look at that in relation to the total patient population. Now I'd like to spend a few minutes talking about FAME-3. This was a study comparing FFR-guided PCI with Cabbage in patients with 3-vessel coronary disease, not involving the left main. And 1,500 patients were randomized to FFR-guided PCI with current generation DES or to bypass. The primary endpoint was the rate of major adverse cardiac and cerebral vascular events, death, MI, stroke, or repeat revascularization at 1 year. The non-inferiority margin was set at a hazard ratio of 1.65. Baseline characteristics are shown here. The average age was 65. Predominantly white men were enrolled with typical risk factors. About 30% had diabetes and 40% were presenting with an acute coronary syndrome. As far as procedural characteristics, the time to procedure, the procedure duration, and the length of hospital stay were all lower or shorter in the PCI arm compared to the Cabbage arm. The number of lesions was just over 4 and similar between both groups. About 20% had chronic total occlusions and about 2/3 had a bifurcation lesion. The mean syntax score was 26 in both groups. The primary endpoint again was MACE at 1 year. And what you see was that it was 10.6% in the PCI arm and 6.9% in the Cabbage arm, with a hazard ratio of 1.5 and an upper bound of 95% confidence interval at 2.2, which was above the non-inferiority margin of 1.65. So this trial did not meet the preset criterion for non-inferiority. When looking at the secondary endpoints, the individual components of the primary outcome, there were no significant differences in death, MI, stroke, or repeat revascularization, or in the composite of death, MI, or stroke, although it was numerically higher after PCI. Safety endpoints occurred significantly less frequently in the PCI group. So severe bleeding, acute kidney injury, and atrial fibrillation were all lower. Fortunately, definite stent thrombosis and symptomatic graft occlusion were both rare occurrences, and rehospitalization within 30 days occurred less frequently after PCI. Now, there was an important interaction with respect to outcomes based on the syntax score. And shown here are the patients who had a low syntax score. And you see that FFR-guided PCI actually numerically was better than Cabbage in this cohort. Whereas in those with an intermediate and a high syntax score, Cabbage outperformed FFR-guided PCI. Was FAME-3 a negative trial for FFR? Well, I think it's important to remember that only 24% of lesions in the FFR-guided patients had an FFR above 0.80. 21% of patients had a CTO, and the mean syntax score was 26. In patients with such complex disease where FFR will be mostly positive, and where we know from previous studies Cabbage outperforms PCI, FFR-guided PCI is less likely to have a benefit or to be able to show a benefit. Now, an important message, I think, that emerged from FAME-3 is that both groups, both the PCI and the Cabbage arm, did better than what was seen in historical controls like the syntax trial. You see here the FAME-3 FFR-guided PCI arm not only outperformed PCI in syntax, but also Cabbage in syntax. And if we had seen a similar event rate as we saw in syntax, we likely would have met non-inferiority. Unfortunately, good for the patients, but not for the study per se, Cabbage did much better than anticipated. So some observations. What is the role of FFR-guided PCI in patients with multivessel coronary disease in 2022? Well, for any test to be useful, one must first follow the results of the test. So if the FFR is above 0.80, then defer PCI. To optimize the benefit of FFR, it needs to be applied in cases where one is not certain about the significance of a lesion. Future Flower MI and FAME-3 all included patients with very low rates of negative FFRs. There is a wealth of data supporting the role of FFR in patients with multivessel coronary disease. FFR-guided PCI is still beneficial in patients with multivessel coronary disease as long as it is applied in appropriate scenarios where it's likely to affect decision-making, and as long as its results are heeded. Thank you for your attention.
Okay, thank you, Dr. William Ferron. So, and after hearing the three important lectures, we're gonna have an interactive discussion time. So, I would like the first question, Dr. Ajay Katani, and we are interventional cardiologists waited a long time the primary result of the FAME-3 trial. So my question is, as the interventional cardiology aspect, how can you apply the FAME-3 result in your daily practice? Can you comment on that?
Thanks so much for having me, and it's been a great session thus far. My take on this is, as an interventional cardiologist, we're also clinical cardiologists, and we take care of patients with the spectrum of disease, and we treat them medically, and sometimes we refer them to surgery, sometimes we do PCI. And so with the advantage we have is we can offer all of those therapies as necessary for the patient. My sense of this specific trial is that it does test the physiologic premise. One thing that's been talked about a lot is it misses the premise of, if you're going to offer PCI, then you really need to do it in the most high quality way possible. And the imaging aspect and the underuse of imaging in that way is really, really relevant. Similar to surgery, you have to do procedures in the most complete way and with the best technique. If you don't do it that way, then that's going to be a problem. But that doesn't mean that we should ignore the results. And I do think that the points made about the 1-year results, this is the 1-year data we're seeing, are largely going to be even greater at 3 and 5 years, which we've seen in every trial of surgical revascularization versus PCI for complex multivessel disease. And so that issue of late myocardial infarction specifically is one that gives me concern, and we will see as these data get spelled out. So at the end of the day, how I would summarize this is that it's important to use best clinical practices. Some of the data that Bill has presented previously have shown that those patients that had significant atheroma volume, lots of plaque burden, we don't need to be doing FFRs. Those patients should obviously be triaged towards a surgical revascularization strategy. On the other hand, we want to make sure that we utilize FFR to eliminate unnecessary PCIs that don't need to happen. And I think that's really the most beneficial aspect of the use of FFR in clinical practice.
Great. So I would like to question to Professor Javier Escanet, and you are expert in imaging and physiology. Looking at the New England Journal of Medicine editorial comment is one of the major limitations in FAME-3 trial is just 11% intravascular imaging was used for PCI. How do you think, if you're gonna use more proportion is optimized in IBUS or OCT based, can you expect another primary result? How do you think?
Yeah, thank you. And it's a very good question. I think that obviously FAME-3 trial is exploring, as Ajay has mentioned, the impact of including one important development in PCI strategy, that is physiology-guided revascularization. And as Ajay mentioned, and as we already saw in the FAME-3 trial, this leads to avoid unneeded interventions, which is, of course, one of the, as cardiologists, one of the first objectives of our treatment. But I think that what it has been left out from my personal perspective, and as one of the PIs of the SYNTAX-2 study, are many other developments that are very important, starting by selection of patients. The interaction between anatomical complexity and outcomes that was shown by Bill before is something that we could not observe in SYNTAX-2, because in SYNTAX-2 we started from the very beginning to acknowledge that there are certain patients, no discussion, that are better off with surgery. And that's something that to identify these patients, you need to use new developments, new scores that are not based only on anatomy, but also on clinical characteristics, like the SYNTAX score 2 and now the SYNTAX score 2020. And once that you have identified these patients where there is no question for us as cardiologists and for surgeons that these patients do better off with surgery, then is when we can really start seeing what is the effect of a combined, and as I say, systematic incorporation of all the developments that have taken place. FAME-3 incorporates physiology and new generation drug-eluting stents, but leaves out the proper stratification of risk of patients, leaves out the use of imaging, and leaves out the use of modern techniques of advanced revascularization. Remember that CTO revascularization is something very important to achieve what Professor Taggart mentioned, that is complete revascularization in patients with triple vessel disease. And I think that the CTO in a patient with triple vessel disease has complete different impact on survival and a long CTO in a single vessel disease patient. So I think that, all these are question marks. In any case, a very important message of FAME-3 is the outstanding results of the surgical arm. That's something that is really interesting and is really food for thought, because honestly, we did not believe that there were as many developments in the surgical technique as in the PCI technique. So that's something that, of course, needs to be, re-examined.
Great. So I'd like some here comment from Professor Adrian Benning, and FAME-3 trial also criticized. We now live in the ischemia trial era. On the basis of ischemia trial, recommendation of bypass surgery was 2 steps down, So NEJM editorial is commented, FAME-3 trial just compare PCI versus bypass surgery. However, they criticize, active comparator, appropriate comparator OMT should be added also. If OMT was added in the FAME-3 trial, how do you think? Is OMT should be active comparator in the FAME-3 trial? If OMT was added in FAME-3 trial, how do you expect the final result? Okay, you are muted. Okay, Adrian, you are muted. Can you? Okay, Professor Adrian, you are muted. Okay, great.
Excuse me, sorry, Dokwu. It's a very good question. Essentially, optimal medical therapy should obviously be part of all of our patients' therapies. And I think that's a given, and perhaps both as cardiac surgeons and as interventionists, we've not really concentrated on that hard enough, and perhaps we've been far too focused on the procedures that we do. From my perspective, I think there are some limitations in FAME-3. I think there is a selection bias. And I would draw our memories back to the original Syntax trial. That in Syntax there was a control trial, control group, where patients who were clearly going to do well with surgery went into that group, and it was clear that those patients did extremely well. Interventional cardiologists know which patients will do well with surgery, and I think that has always been the case. And I suspect in FAME-3 there was a bias there that a number of patients were taken and treated with PCI. There was then a group of patients where PCI was difficult or PCI was not obvious, and they were randomized in the trial. And I think that weakened the ability of physiology, which main strength is obviously to decide which lesions need to be treated and which lesions can safely be deferred. Javier and I have recently published Syntax 2 trial 5-year follow-up. And in the context of these data, I think it's very interesting that we show at least equivalence at 5 years between contemporary PCI and the surgical results we saw in Syntax, combining the techniques that Javier has mentioned, physiology to decide when to do it, imaging to make sure we've done it properly, complete revascularization with contemporary techniques for CTO. Very importantly, using an algorithm to select which patients should be treated. And I think going forward, this kind of confrontational view between surgeons and PCI doctors is probably wrong. I think with AI, we will move to a position where the computer will be telling us which patient should be treated, how they should be treated, and perhaps who should be doing it. And I think ultimately that will be a much better to tailor our therapies for individual patients based on the anatomy, on the patient, and on the expertise in the environment that they find themselves in.
So I heard after release of ACC/AHI new guideline, many cardiac surgeons disappointed to step down bypass surgery for treatment of multivessel disease. I'm sure many audience want to, expert comment cardiac surgeon David Taggart. How do you think recent updated ACC/AHI guideline? Do you think appropriate, or I would like to hear your opinion for recent.
Well, thank you very much, and congratulations to all the great speakers we've had and the great debate we've had. But to be honest, I think the surgeons have got it right this time. If you look at what ACC have done, they've downgraded Cabbage with no new evidence, but based on a misinterpretation of the ischemia trial. So what they've done is completely wrong. And the other thing that concerns me about what they've done is I think by going down the route they have is we have all of us here spent the last 10, 15 years trying to improve the concept of the heart team. So I don't think they just got the science wrong. I think they've got the philosophy wrong. They've now reopened a wedge between surgeons and cardiologists, not based on any evidence. So that troubles me. But I would also have to say, if we look at what we've discussed today, FAME-3 is essentially telling us what we've always known and what all the evidence has shown for 20 years. And the focus of the interventional cardiologist has always been trying to improve the design of the stent to treat a culprit lesion. And that's great. The problem is for many patients, they have diffuse coronary disease. And no matter how good your stent is to a localized proximal culprit lesion, it doesn't offer any protection over 5, 10, 20 years of future progression of disease. And this is what syntax showed us. The reason I believe patients with low severity syntax disease do so well is by definition, they have relatively localized disease. They do not have a coronary artery full of distal diffuse disease. And I think that's why patients with low syntax scores do very well with a stent, because it is the localized proximal culprit lesion. But once you get outside these low syntax scores, the pathophysiology is telling you this patient has multiple diffuse disease, and a localized stent cannot offer protection over the long term. So I am honestly not surprised by FAME-3. I would congratulate the FAME-3 investigators on their honesty in the way they've presented their data. But I absolutely predict, as Javier said, if you look at these patients at 5 years, that gap that you see accelerating at 1 year is going to be much wider.
Okay, great. So, and Dr. Case Allen, is any comment on the FAME-3 result and the recent updated guideline?
Well, my only comment would echo the other speakers in that it seems the more we study, the less we actually seem to learn. We all come with our own packages and baggages of bias. And I think ultimately it's like a milking stool with 3 legs. You've got the patient, the cardiologist, and the surgeon. And each one plays a vital role in deciding their therapies. And too often, we look at the patient as just a statistic or a checkbox, and you really need the heart team to look at the patient to try to decide what their medical issues, what their comorbidities are. And it's not just about the lesion set. It's, can you get them through surgery, and is 30 days adequate? Obviously not. And 1 year isn't adequate either. So in the long haul, you're trying to get these patients to a better place and improve their survival long term. And that really takes a communal discussion. And I think FAME-3 is a very honest look at all of this, but the guidelines, as David said, I believe have disrupted that communication and that collegialness that we had built up over the last 10 years. And I think that's a very bad thing to do.
Great. Okay, Jungmin An, any question or any comment to presenter and lecturer?
Yes, every data, as mentioned by Dr. Tagat, every data showed that bypass surgery is better than PCI in the complex triple vessel disease. So as your interventionist, I felt a little bit frustrated, but I think it's good time to consider the quality of PCI. In FAME-3 trial, only 10% used the imaging guidance. In addition, 20% CTO, 60% bifurcation disease. So I'm not sure the interventionist on average can treat such a complex lesion appropriately. So similar to the kind of center of excellence in the mitral repair, for the very complex disease, I think we need some center of PCI excellence, center of excellence for PCI, such kind of concept. That's my comment. Thank you.
Okay,
that's really where imaging comes in. You see, if we image, not only do we make sure our stent is properly deployed, but we're also absolutely sure that we've covered the disease. And David's right. If you don't cover the disease with the stent, then the stent doesn't work. Now, sometimes you need to extend your stent. Sometimes your stent needs to be bigger. But if all you do is put it in and assume it's fine, I can guarantee many of the times it won't be. Actually, we have concentrated too much on the stent. We've concentrated too much on stent restenosis and on drugs that make restenosis less of a problem. But often it's not restenosis, it's persistent stenosis that we didn't treat the first time. So I think, this is a call for us to improve our technique. It's a call for us to improve the scrupulousness of our technique and to make our interventional results better.
Yes.
Great. Okay, and the Spencer King, and I think it's now looking at the current available data, and the protective cardiologist ischemic trial is prevailing all the recommended evidence. So, and Professor Spencer King, you are pioneer of the PCI. How do you think the updated guideline and the recommendation is in the aspect of your long history of the PCI pattern?
I don't think the argument in the future will be between methods of revascularization. I agree with, I think, everyone that our whole approach is so different now, where we sit with the surgeons and pretty much everybody agrees. I mean, there are things we don't know, we need to know more about. We need to know about surgical turndowns and why they're turned down. We need to know about surgical cases that are done that really probably should not have been done because there's a diffuse disease, they didn't turn out as well. We need to know about what can be done at each local institution. When I was active in doing angioplasty, I would have had a very different selection for PCI and surgery than I would do now with people who can achieve with new techniques. As young men has said, there are ways to achieve revascularization that look almost similar to surgery. And despite the fact that arterial grafts are the great thing, we know that the vast majority of people do get in multivessel disease a lot of vein grafts. So I think one problem I have with our trials is that we keep we want a lot of patients, we want a lot of endpoints, we want to have a lot of inclusion, but by doing that, there are a great many patients where we probably have no equipoise in our own mind. So we don't put them in the trials. If we sit down where we have true equipoise, I think we could learn something. Yeah, with a vaccination for COVID, we didn't know anything. We can have a trial. We can give half the people vaccine, the others not vaccine. We don't know the outcome. We're not biased toward it, and we get a result, and it's compelling. We're a long way from that. We have years and years and years of experience, bias, expertise, everything added up to get into that heart team discussion. And we pretty much decide what we think ought to be done. So I'm a little pessimistic about where we go in future trials to answer this completely. I am impressed that we're making progress. And I think the discussion, the conflict, if we're going to have conflict in the future, will be when we're using CT angiograms pretty much routinely. We see how much disease the patient has. That is told to us by a radiologist or perhaps a cardiologist who reads them. And now it goes back to the primary physicians and all kind of other people who are saying, okay, now they want to revascularize, but this is not a fight anymore between surgeons and cardiologists. It's, can you prove to us that they have to be revascularized, because we have very powerful medical therapies, and we want to know that you're really extending the life by revascularization. So I think that's our challenge for the future.
Okay, great. So I think our time is over. I think they really appreciate all the lecturer or panelists. And this time is a very nice and thoughtful, interactive discussion between cardiac surgeon and also the cardiologist. And this is a very the useful, helpful to understand how can you do the multivessel revascularization after FAME-3 trial. Thank you all of them to contribute our TCTAP meeting. I hope all of you see in-person meeting next year, TCTAP.
Let's hope so.
Yes, 2023. Thank you. Thank you. Great.
Thank you very
Congratulations
much.
on the
Thank you.
meeting.
Thanks, guys.
Thank you.
Thanks.
Thank you.
Thank
you.
you.
Bye.
See you next year.
Great
Thank
meeting.
you.
See you
Thank you.
next year.
Thank you. Thank you very much.